pneumonia, the very important, the mistreated, misdiagnosed condition, the entire world, the two very common in our part of world. So pneumonia, to begin with, is an inflammation of the lung parenchyma. This is a simple definition that everybody of us know. This has got a significant morbidity and mortality. Each hour, a patient dies of pneumonia. It is often misdiagnosed, mistreated, and underestimated. The people tend to miss the simple diagnosis. It is very simple to read, very simple to write in exam, very simple to practice, but in day-to-day practice, it is often underestimated because many physicians do miss the diagnosis. After the diagnosing, they mistreat it. Either they don't receive treatment or they receive inappropriate treatment. The treatment for pneumonia is very, very important because infectious disease is one part of internal medicine where we have got the best treatment available. If you see the neurological aspects, the rheumatological aspects, the treatment tends to be lifelong. Although the morbidity will be very high even with a good level of treatment. But in infectious diseases, a right diagnosis and a right treatment is going to completely cure the patient. So it is very important to know everything about pneumonia. So both the undergraduates and the postgraduates and the practicing physicians should know pneumonia in detail. So if you know the mortality rate of this pneumonia in last 30 years, from 1990 to 2020 almost, the under 5 mortality due to pneumonia has reduced significantly. But if you see, the old age pneumonia deaths are actually increasing. Like if you see the percentage here, the most number of deaths among the total deaths is the older patients. That means the pediatricians are doing pretty good in their job, but it is the physicians and the geriatric specialists, they are not to the mark in reducing the global burden of this pneumonia deaths. So it is one of the most common cause of infectious death in worldwide. If you know what is the most common infection which is causing death in worldwide, it is pneumonia. So if you ask me what is the most common cause of pneumonia, the same question, if it was put to me 12 months back, then my answer would have been the COVID-19. But after the COVID-19, the epidemiology of this community-acquired pneumonias has significantly changed. The bacteria have been pushed to the second place by the viruses. So nowadays, if somebody asks you what is the most common cause of community-acquired pneumonia, then without any hesitation, we can tell the viruses as the most common cause. Although for all the exam purposes, the most common organism which is causing community-acquired pneumonia still is the streptococcal pneumonia, but the respiratory viruses should be always kept in mind before dealing with the management. So as far as the classification of this pneumonia according to the guidelines is concerned, it was usually classified as community-acquired pneumonia and the nosocomial pneumonia. The nosocomial pneumonia is again classified into the hospital-acquired pneumonia and the ventilator-acquired pneumonia. So there was a terminology called healthcare associated pneumonia, that is HCAP. This entity was included in the earlier guidelines given by the IDSA and American Thoracic Society, whereas in the recent guidelines, this definition has been withdrawn. Nowadays, we remain with only 3 types of pneumonia, that is community-acquired pneumonia, where the pulmonary parenchymal infection is occurred in a patient who is not hospitalized or residing in a long-term facility for 14 or more days before the presentation. He has nothing to do with the hospital in the last 14 days. He has not visited the hospital in the last 14 days, and he has not remained in the hospital. If a patient comes with pneumonia, then it is community-acquired pneumonia. So after hospitalization, after the second day, the third day, if he develops the acute parenchymal infection of the lung, then it is called hospital-acquired pneumonia. If this same parenchymal infection occurs after 2 days of this endotracheal intubation or mechanical ventilation, then it is called ventilator-associated pneumonia or ventilator-acquired pneumonia. So the definitions are very, very important. Within 48 hours, if a patient develops the pneumonia, then it is not hospital-acquired pneumonia, then it is community-acquired pneumonia. the infection should occur after 48 or more hours after the hospital admission. This is very, very important definition. Why this is important? Because the organisms, if you see, to cause the community acquired pneumonia in the community area, it is different from the hospital area. In the hospital, we have got lot of resistant pathologic organisms causing the pneumonias. So these people tend to behave very severely. These people will receive a very high level care of management and a very high level of antibiotics. So it is very important to categorize the patients as community acquired pneumonia and hospital acquired pneumonia, because the treatment is going to change. You cannot consider the treatment similar for both the conditions here. So in diagnosis, whenever you consider the pneumonia, always try to mention whether it is a community acquired or a hospital acquired pneumonia. So the healthcare associated pneumonia was included in the earlier terminology. Here, if at all the patient is residing in some nursing home for the long time, if the patient is receiving home antibiotic therapy, if he is coming for dialysis regularly, if he is receiving chronic wound care, like patient is coming for daily dressing of the wound, patient is receiving weekly chemotherapy, all these were considered as healthcare associated pneumonia. But this terminology is not being used nowadays. There is no terminology called healthcare associated pneumonia. Why? Because this led to a severe increase in the incidence of severe pneumonia and a wrong practice of using the higher antibiotics in a stable patients. For example, if a patient is receiving dialysis, in this category, if patient develops pneumonia, he would have been considered under the category of healthcare associated pneumonia, ultimately making him to receive a very high or broad spectrum antibiotics, making him more prone to develop more severe infections. So that's why this terminology has been withdrawn. Nowadays, there are only two terminologies, that is community acquired pneumonia, the hospital acquired pneumonia, and ventilatory acquired pneumonia. So the community acquired pneumonia is a very, very important thing which every doctor should know about. So this is an acute infection of the pulmonary parenchyma in a patient who has acquired this infection in the community. So this infection he has acquired from his daily, his home setting or his daily work setting. This is acquired in the community. So this is a common illness. That's why we should know. And this is a potentially serious illness. This patient can make the patient suffer a lot, both physically, mentally, financially, and ultimately it can cause death. If you work in a ward, you will definitely know the seriousness of the condition. Especially the old age people, they are very prone to develop this community acquired pneumonia, where treatment becomes very, very difficult. So it has got an associated considerable morbidity and mortality. And in India, if you see the statistics, it accounts for the 23% of the global pneumonia burden. So 1/4 of the total world's burden is being taken by India. So we need to be very careful regarding this. And case fatality rate is very, very high in India. It is 14 to 30%. So 14 to 30% is a very big number. You see 100 patients, 15 to 30 are going to die from pneumonia. So another cause for this case fatality rate and increased incidence is the very poor antimicrobial stewardship in India, both at the basic level and even including the tertiary care level. The antimicrobial stewardship has been very, very poor. Nowadays, this has become a very big issue. If the same condition goes on, our third and fourth generation next to us will not be left with any antibiotics to receive for the infection. So we need to practice antimicrobial stewardship in day-to-day practice. In simple words, what is antimicrobial stewardship means? It means the right antibiotic at the right timing, at the right dosage. So don't give antibiotics unnecessarily, or if there's a condition which definitely needs antibiotic, you need not hesitate in giving. Whenever you're giving antibiotic, always look your dose once again and cross-check the dose which you are using the right way or wrong way, the timing is being right or not. So this all been the very, very important issues. So if you see any hospital, go through the treatment chart, whatever the drugs they are using, what is the dose they are using, what is the timing they are using, this becomes very, very important. So if I ask you the dose of some antibiotic, many of the people will definitely answer it wrongly. So because we know the name of antibiotics, but sometimes we don't know the right dose at the right timing, etc. So many of the hospital, for one of the example, if you see the most commonly used antibiotic, that is the piperacillin tazobactam. If you see any tertiary hospital, alternately every patient will be receiving this antibiotic. Many of the people don't actually know what is this piperacillin tazobactam, but yet they tend to use it as a sepsis guidelines. So the right dose of piperacillin tazobactam is 4.5 gram 6th hourly. So the next exercise you can follow is go to the hospital, check for the patients who all are receiving piperacillin tazobactam, and check which all patients are receiving this right dose. Many of the people do practice 4.5 gram BD, that is 12 hourly, 24 hourly, 8th hourly, whatever the way they want. So this is a very common example that they practice in a wrong way. So antimicrobial stewardship is a very important thing that you younger doctors should continue to take it to the further generations. It is just the right antibiotic at the right time at the right dosage. And the pathogenesis of pneumonia, you might have already studied in the pathology parts. So this is basically earlier considered as the pathogen invasion of the sterile space. So this was the major pathogenic mechanism causing the pneumonia, because initially the lungs were considered as free of any microbes. But nowadays, the hypothesis has been proven wrong, because even we have got the alveolar microbiome, which are normally situated in the human lungs. Just like the gut microbiome, the human alveolar or the respiratory parenchyma has got its own microbiome. So for infection to occur, there has to be a disruption between the alveolar microbes and an extra pathogen which is coming from the outside. So this alveolar microbe is similar to the oral cavity. This is basically filled with microaerophilic streptococci, the pivotella, all these anaerobic organisms. So normally these are situated in our lungs, which are existing in the lungs, are very, very important for the host responses. So these compete with the extra organisms which we are usually exposed in a day-to-day life by the aerosol mechanisms, etc. So whenever some bacteria enters into the respiratory tract, we have got lot of the defense mechanisms. One of the defense mechanism is the existing microbiome which is situated in the lungs. So this is very, very important. So the new pathogenesis of the pneumonia is the disruption of the balance in the existing microbes. If this number is outgrown to the normal number, or if the invasion of such an organism which is much more pathogenic than the existing organism, this can occur or this can lead to the development of the parenchymal inflammation of the lung. So earlier it was thought that the introduction of the new pathogen is the only cause of the pneumonia, but nowadays this pneumonia can occur even with or without the introduction of the new organism. So we know that our lungs are constantly exposed to many particulate matters and the microorganisms. For this, we have got the number of the host defense mechanisms, that is non-specific and specific immunities which are dealing against these things. So whenever there is introduction of a pathogen into the alveolar space, for example, a new bacteria has come into the alveolar space, normally this alveolar pathogen is being dealt by the host mechanisms. For example, there is a sputum production, this organism is get excreted through the mucociliary clearance. This can be dealt with the alveolar macrophages, the got affected A, B cells. All these are the local immunity cells which deals with these organisms. Whenever the inoculum is very high, so this cannot be dealt by the number of alveolar macrophages which are situated in the alveolar cavity. So if the pathogen is very high inoculum or a very high virulent organism has acquired through the infection, this will trigger local inflammatory response by secreting the cytokines. So this local inflammatory response, if it cannot overcome the infection, this will stimulate a systemic inflammatory response where it stimulates the bone marrow to produce the more and more the lymphocytes or neutrophils and macrophages to come for the fight against the bacteria. So this will cause the systemic symptoms in the pneumonia. So normally this will the systemic inflammatory response along with the local inflammatory response will contain the pathogenic organism, which will be cleared off in the due course. If this systemic response or inflammatory response, if become dysregulated, like if there is an overwhelming systemic response to the inoculum, this may lead the patient to go into sepsis or the cytokine storm or the multi-organ dysfunction, which we usually see in the patient. So this is very, very important mechanism of action why some patients go into sepsis. And we know that certain bacteria and viruses possess their virulence factors. Some may have the celiostatic factor secretion, some may have the anti-capsulating organisms, some may actually reduce the alveolar pathogen production. So all bacteria has got its own virulence factors. You might have learned in the microbiology. One very, very important virulence factor which you should know is about the influenza virus. This influenza virus is very notorious in reducing the tracheobronchial mucus velocity. So normally the mucus moves along the mucociliary area. So this moves with certain velocity. This influenza reduces this tracheomucus velocity as soon as it gets infected, up to 90 days after the infection. So that's why the influenza patients are more prone for development of secondary bacterial infection, especially caused by the Staphylococcus aureus. So influenza reducing the tracheal mucus velocity has been a proven thing in causing the virulence factor associated with this virus. And along with this, there are some predisposing host conditions which makes some people very prone to develop this particular pathology, like the older age, where people are more prone to develop the aspiration, then some chronic pre-existing lung disease, the COPD, cystic fibrosis, heart failure, any bronchial obstruction which can cause post-obstruction pneumonia, lung cancer. The previous episode of pneumonia makes the person more vulnerable to develop next pneumonia and immotile cilia. Then any patient who would having increased risk of microaspiration, like patient of any level of alteration in the sensorium, patient who is not able to swallow properly, and patient who tend to wear dentures even while sleeping. And immunocompromisation obviously increases the risk. And then some lifestyle factors which are definitely modifiable, like smoking, alcohol, drugs, the toxic inhalations, all these things are very important. And any amount of inflammation to the respiratory tract, like if you're undergone the patient for the bronchoscopy, if the patient is endotracheal intubated, these patients are definitely more prone to develop the organisms. And again, the viral respiratory tract infection makes the patient more prone to develop the bacterial respiratory infection. And there are some drugs which have got some relation with the pneumonia. So if you see the acid reducing agents, that is both the PPI and the H2 receptor blockers, increases the risk of community acquired pneumonia. This is very, very important. This is because normally the gastric acidity is the innate immunity which we possess in our body. So the drugs which reduces this gastric acidity, reducing the innate immunity, many of the organisms which we consume or ingest will usually be handled or will not be able to withstand the gastric acidity. So if we reduce the gastric acidity by the chronic use of this proton pump inhibitors or H2 receptor blockers, the patients are definitely more prone to develop the pneumonias and also the Clostridium difficile infection or the antibiotic associated diarrhea. All these are very, very common in case of the PPIs. Then antipsychotic drugs are typical more than the typical, like the risperidone, the quetiapine, aripiprazole. All these are in study have shown to increase the risk of pneumonia, especially in the elderly people. Sometimes there are case records of the fatal pneumonias caused by the antipsychotic drugs. ACE inhibitors are the one drug which have shown the protective results in observational studies. although the randomization studies have not been conducted in this particular hypothesis, but some observational studies, this has been found that ACE inhibitors tend to reduce the risk of pneumonia. So the glucocorticoids, again, by causing immunosuppression, can cause the increased risk of pneumonia. Even the inhaled glucocorticoids for some the COPD or asthma, if the patient is on chronic inhaled glucocorticoid therapy, are very much prone to develop the community-acquired pneumonia. Again, the drugs like sedatives, by reducing the sensorium and increasing the occurrence of aspiration, can cause the pneumonia. So only drug which seems to protect you against pneumonia is the ACE inhibitors. That too is an observational study. So next, coming after pathogenesis, next coming to the microbiology. We know that there are typical organisms and atypical organisms causing this pneumonia. Earlier, the pneumonia was also classified as typical and atypical pneumonia. Even still today, these terminologies are in use. So what is typical and what is atypical about these organisms? So these typical organisms tend to produce the lobar pneumonia, and they are inherently sensitive to the beta-lactams and the macrolide antibiotics. So this is a typicality about these organisms. So what is atypical about these organisms is they are usually not or inherently resistant to the beta-lactam antibiotics. So this is very, very important. So the typical and atypical, the terminology actually originated by the susceptibility to the beta-lactam or penicillin group of antibiotics. So all these were initially sensitive to the penicillin group, and these were found to be resistant to the penicillin group. So what are the typical organisms? So it is the Streptococcal pneumoniae, the H. influenza, the Staphylococcus aureus, the group A Streptococci, the Moraxella catarrhalis, the anaerobic organisms, and the gram-negative bacilli like the Pseudomonas, the E. coli, Klebsiella, all these causing typical organisms. Another typicality about these is they are stainable by the gram stain, whereas these all organisms are usually not identified on the gram stain, and they are not easily culturable. So there is a lot of atypicality about these organisms. So what are those atypical organisms? So those are the Legionella species, the Mycoplasma pneumoniae, Chlamydia psittaci, the Chlamydia pneumoniae, and Coxiella burnetii. These are the atypical bacteria which can cause the community-acquired pneumonia. This is very, very important. You might have already studied these in the pathology or the microbiology things. Then there are very important respiratory viruses, that is influenza A and B, and the SARS-CoV-19 is a new hero. And the rhinoviruses, the parainfluenza viruses, the adenoviruses, and the human metapneumoviruses. But basically, the viruses are the most common cause of this, the bronchiolitis or the bronchitis, whereas the pneumonia per se is still now considered as the bacterial origin. So if you go through the literature, the more than 100 microbiomes are actually identified to cause the pneumonia, and they actually vary in the clinical setting. In the next slide, we are going to learn what kind of patients are prone to develop particular organisms. Then in routine clinical practice, the etiological agent is usually not identified. If you go to the medicine ward and look at the pneumonia patient, 90% of the times the patient or the treating doctor does not know which bacteria is responsible for this. So in routine practice, they usually don't find the organism, and even if they're interested, it is very difficult to find the organism. And overall, the most common bacteria causing the community-acquired pneumonia is Streptococcal pneumonia. Then this COVID-19 has definitely affected the epidemiology of the community-acquired pneumonia. And these atypical pathogens are very difficult to identify and also difficult to treat. Then in selected group of patients, there are 3 organisms which we are usually fear of. One is the Staphylococcus aureus, that is MRSA, and the Enterobacteriaceae species, then the Pseudomonas. So these are very, very important pathogenic organisms, or sometimes multi-resistant, drug-resistant organisms, which we usually fear of in our patient. Then etiology of pneumonia in a region is dynamic. The area which you are practicing may have its own predisposition So people are more prone to develop some kind of pneumonia uh, caused by definite organisms. So you need to know the local trends, definitely. So what are the important trends which are going on in the world right now is the decline in the streptococcal pneumonia incidence, mainly because of the widespread vaccination. Nowadays, the pneumococcal vaccination has become very rampant even in adults, so which has brought down the incidence to a pretty low level. And also due to the development of herd immunity, because all the children are routinely getting vaccinated to the pneumococcal and H influenza vaccines. Then this COVID has definitely affected us a lot. Then there are more and more respiratory viruses are under recognition. We don't know what is coming to us in the future time. We might get discovered with the new uh, viruses or in the bacteria in the coming times. And overall rate of the pathogen detection is very, very low. And nowadays, the discovery of lung microbiome has affected the microbiology of the community acquired pneumonia. The lot of researches are going on in this particular thing. And before dealing with any community acquired pneumonia, before acquiring the treatment, learn about the local resistant of the antibiotic. The textbook may say something, but your local practice is better judged by yourself. So you might, if you are very sure that some antibiotic is not going to work, even if they mention it as a first line therapy in the guidelines, you may not choose to put it on. So this is very, very important. Then this is a chart which is available in every textbook, which you should go to learn about the epidemiological risk factors associated with certain bacteria or the certain viruses, etc. This is a very important slide to remember. So here, what are the most common microbial causes of the community-acquired pneumonia by the site of care? So in this outpatients department, community-acquired pneumonia, where if the community-acquired pneumonia, the patient is being treated on the outpatient setting, then the organism is either streptococcal pneumonia or mycoplasma pneumonia or H influenza or chlamydia or some respiratory viruses. If the patient is admitted in the hospital, then it is either the resistant organisms of this, which has increased the inflammation, or the Legionella is usually makes the patient to get admitted into the hospital, and respiratory viruses like influenza and COVID especially. Some ICU, you have got specific organisms, that is the resistant streptococcal pneumonia, the Staphylococcus aureus, that is MRSA, is very notorious. Then gram-negative bacilli, that is E. coli, Klebsiella, and the Pseudomonas. All these are very, very important in the major organisms causing community-acquired pneumonia of patients admitted in ICU. And again, the pathology, everybody of us know that the stage of congestion will progress to red hepatization, progressing to gray hepatization and resolution. So this I'm not going to take here because this is a pathological discussion. So the clinical presentation of community-acquired pneumonia, as a pulmonary features, we have got cough is a predominant symptom with or without expectoration. The expectoration in a case of pneumonia actually helps us for the identification of the organism better way by the Gram-Stain and culture sensitivity of the sputum producing. And the dyspnea may not be there in a mild patient, but is definitely a feature of the severe pneumonia. Then pleuritic type of chest pain due to associated pleuritis. Then the signs, if you see, there is usually tachypnea can be seen, increased work of breathing can be seen. Then the examination findings, we know that patient can have bronchial breathing, the tactile primitus, the egophony and bronchophony, dullness on percussion, crackles and rhonchi, all these can coexist in these patients. So this is an examination finding which everybody of us know. And along with this, there are some systemic features, that is fever, with chills, fatigue, and malaise can be there, anorexia can be there, nausea, vomiting can be there, diarrhea can also be there in the patient, mainly caused by the Legionella. If at all a patient of community-acquired pneumonia is coming with predominant diarrhea, you need to suspect Legionella. Another clue to the Legionella pneumonia was the hyponatremia developing in a patient of the community-acquired pneumonia. Then always look for the signs of sepsis, which guides the site of treatment in the patient. How to make the diagnosis of the community-acquired pneumonia? So community-acquired pneumonia is diagnosed when a patient with clinically compatible symptoms like a fever, dyspnea, and cough with expectoration in acute setting If a patient coming with 3-day history of fever, cough, expectoration, then he is pneumonia until unless proved. So this patient is being taken to the chest imaging. If the patient demonstrates the chest infiltrates in the chest imaging, then is definitely a case of pneumonia. So this chest imaging can be of two types. Either it is a chest X-ray or the computed tomography of the chest. In the 99% of the patient, it is the chest X-ray. Only in some patients, we may prefer the CT chest to diagnose community-acquired pneumonia, or the majority of the purposes types, the computed tomography is actually used to rule out pneumonia. Like if you're suspecting any other diagnosis, if your suspicion is towards the malignancy, if your suspicion is towards the tuberculosis, all these can take towards the computed tomography. Otherwise, if a patient of a clinically compatible symptoms coming to you with the chest infiltrates on chest X-ray is definitely a case of pneumonia until unless proved. So in chest X-ray, we have got variety of the presentations in community-acquired pneumonia, but it usually presents the three abnormalities, either as a lobar consolidation, then one particular lobe is involved. If you see this particular X-ray, this patient has got the right upper lobe consolidation. Sometimes patient may also have the bilateral infiltrates. So if you see here, the patient has got bilateral infiltrates. The terminology was used for this particular type is the bronchopneumonia or the pneumonitis, bilateral pneumonitis. Some people tend to use this terminology, and sometimes it can be associated with the cavitatory findings inside the consolidation. If you see the cavitation or the breaking of the consolidation here. So all these are considered as community-acquired pneumonia. Some people believe that only lobar pneumonia is considered as community-acquired pneumonia. This is wrong. Even the infiltrative type of pneumonia and the cavitatory type of pneumonia is also considered as the community-acquired pneumonia if the clinical persistent symptoms exist. Like if a patient of this X-ray presents to you with a 3-day history of fever, cough, expectoration, and dyspnea, then it is community-acquired pneumonia only. This is very, very important to know. The CT is not usually go to test in case of community-acquired pneumonia. Only in some settings where you suspecting the patient to have a community-acquired pneumonia, but your chest X-ray comes negative. This can occur in immunocompromised patients and some pneumonias due to abnormal epidemic pathogens like Legionella, where you can go to get the CT scan to diagnose the patient. But in these patients, getting CT does not affect the outcomes. Nowadays, the latest guidelines also tells that if a clinically compatible symptoms are present, even if the chest X-ray is negative, treat the patient as community-acquired pneumonia. For example, if a patient comes to you with the complaints of fever, cough, dyspnea of acute duration, sometimes the initial chest X-ray may be normal. This has been very true in case of the patients who are dehydrated. Patients who are dehydrated at the initial time may not have any chest infiltrates. This is also called as blossom hypothesis. After the rehydration, the patients are going to develop the infiltrates, so which might confirm the diagnosis of community-acquired pneumonia. So this is very, very important whenever you have a clinically compatible syndrome. Like any patient coming to you with a fever, cough, dyspnea of an acute duration, treat him as community-acquired pneumonia, even if it is chest X-ray is normal. Like if the patient does not have any signs of sickness, like patient is not in sepsis, patient is not in respiratory failure, you have decided to treat the patient as outpatient, you need not get the CT in this patient also. But if at all you are admitting the patient of community-acquired pneumonia whose X-ray is normal, and even after the hydration, his X-ray, repeat X-ray comes normal, then CT is definitely advised to diagnose the patient. So the outpatient, you can treat the patient even without X-ray and CT, whereas admitted patients need to have the imaging demonstration of the infiltrates. Then after labeling the patient as community-acquired pneumonia, the next thing is defining the severity and the site of care. This is very, very important. Yeah, so this defining the severity and site of care, according to me, is pure individual. If you suspect your patient needs admission, you need to admit the patient irrespective of what the scores or what the guidelines tell. This is very, very important in nowadays, because of a lot of the harassments are going towards the doctors, and the mismanagement by the patient attenders are occurring in day-to-day practices. So if you think your patient needs ICU admission, better admit in ICU, even if his curve 65 is normal, even if his pneumonia severity score is normal. So this is purely individual definition. All these scoring systems are basically developed for the study purposes. So the day-to-day practice, it makes difficult for you in practice. So we have got two scores available, which are very commonly used in defining the severity of the pneumonia. The very important among that is the Pneumonia Severity Index, or PSI, are also called as POTS scoring. This is a very well-validated tool which is being used in practice in determining the site of care of the pneumonia patients, whereas curve 65 is a very simple one, but the validation is been not appropriate in this thing. So the curve 65 scoring actually involves the 5 factors. Among that, one is confusion, another one is the blood urea nitrogen, and the respiratory rate of more than or equal to 30, and systolic blood pressure of less than 90 or diastolic of less than 60, age more than 65. Each point carries 1 point. So this actually detects the 30 days mortality in a patient. So any patient with a score of more than 2 needs hospital admission. This is very, very important. So this is a very simple tool to practice. Even sometimes there is a new tool also called as CRB65, where it does not need the investigation of the urea also. Like you can just decide in the OPD about the site of care. Like if the curve 65, instead of curve 65, we can use CRB65, C for confusion, respiratory rate of more than 30, blood pressure low, and age above 65. If 2 out of these 4 are positive, then the patient needs to be admitted to the hospital. The pneumonia severity score actually involves many factors like demographic factors, the comorbidities, the physical examination factors, and the laboratory factors. And it is being classified into the 5 classes, that is class 1, 2, 3, 4, and 5. So here 4 and 5 are definitely need the hospitalization. The 1 and 2 can be managed on the hospital-based settings. Whereas 3, it is individualized. You can manage the patient as an outpatient, or sometimes there is a new terminology called brief inpatient care, where the patient comes daily for the antibiotic treatment to the hospital, but patient is not remaining inside the hospital for the entire 24 hours. So this is also very, very important. But there are some limitations with its pneumonia severity index. For example, if you see the comorbidities, the COPD is not been included in this, which is a very important risk factor in developing pneumonias. So all these have got its own drawbacks. So that's why the individualized decision is very, very important in deciding the site of care. Again, I'm repeating the sentence here. If you, the treating doctor, thinks a patient needs to be admitted, the patient has to be admitted. Then according to this, the patient is being classified as mild pneumonia, moderate pneumonia, severe pneumonia in adults. This is different from the pediatrics, where it is classified as mild pneumonia, severe pneumonia, and very severe pneumonia. But in adults, it is mild, moderate, and severe, as simple as that. So in an otherwise healthy patient, we have normal vitals. There is no concern for the complications, and whose PSI score is 1 or 2, and his curve 65-0 is considered as having mild pneumonia and can be decided to manage under the outpatient basis or the ambulatory care. Or if the patient is having the SpO2 of 92, or the PSI score of more than 3, or the curve 65 of more than or equal to 1, is considered as having moderate pneumonia and needs to be admitted to the hospital. And if you see this definition of severe pneumonia, this consists of 2 factors. That is, one is the respiratory failure, which is requiring the mechanical ventilation, and the sepsis, which is requiring the vasopressor support, is considered as having severe pneumonia. So these patients need to be admitted to the ICU. So if you see this, the recognition of this respiratory failure and the sepsis in vasopressor support is actually relatively straightforward. By the time, if you diagnose this condition, patient is already having multi-organ dysfunction, or he may be in septic shock, or all these things. So real challenge is to identify the patient from the moderate to the severe class before going into the septic shock or the respiratory failure. So in identifying these kind of patients where the risk of progression is very high, the American Thoracic Society has given guidelines or the criteria. There are 9 criteria. Among this, the 4 are clinical and 5 are the laboratory based. So in clinical, if at all you admitted the patient, then you see that he's either altered mentally, he's having hypotension, but requiring fluid support. We know that in sepsis, initial choice of treatment in case of hypertension is the fluids. So even before vasopressor support, the patient can be admitted to the ICU. And hypothermia developing in sepsis is also a criteria. Then respiratory rate 30, then the blood urine nitrogen of more than 20, the hypoxia demonstrated by the PF ratio of less than 250. Then leukopenia is a very bad thing in pneumonia. Then again the thrombocytopenia and the multilobar infiltrates. So I will give you an example. If you admit the patient, you admitted the patient of pneumonia who is having the multilobar infiltrates, and he is having the urea of 65. So according to this slide, the patient does not need ICU admission. Patient does not have any respiratory failure. Patient does not have any vasopressor support also. But since the patient is at risk of developing the severity, the patient can be admitted to the ICU in the early period. So among this 9 factors, if 3 are positive, the patient can be admitted to the ICU even before development of the refractory shock or the respiratory failure. So this is very, very important in deciding the management. Then how about the microbiological testing? Again, microbiological testing is a cumbersome procedure. It definitely has a benefit in identifying the organism. Okay, it will reduce the treatment burden. Like we can choose the right antibiotic directly instead of the empirical therapy. Whereas if you see, as I told you, there are more than 100 organisms which can cause pneumonia. There are a lot of time required to identify all these possible organisms, and the cost is also going to be high. So you need to always outweigh the risk and the benefit associated with the microbiological testing. So, but we, in practice, we follow the tiered approach in the microbiological testing. For example, if we have diagnosed the patient as mild pneumonia and we have decided to manage him as ambulatory care, only 2 tests are required. Get him tested for COVID-19 and get him tested for influenza if at all you are under an epidemic or a pandemic. Otherwise, the testing is usually not required in ambulatory care patient. Whereas the admitted patients, if you have decided the patient for the admission under the general medical ward, then along with the COVID and influenza test, the very important things are the blood culture and the sputum culture. These are very, very important things. The patient needs to be sent to the blood culture and the sputum gram-strain culture before the antibiotic receival. Along with that, get the patient the respiratory viral panel and the urine streptococcal antigen and the Legionella testing, along with the testing for HIV. If you have got specific risk factor for the occurrence, like if you are suspecting the patient of MRSA, you can get the cultures for MRSA also, or you can also get the real-time PCR of the nasal swab to diagnose for MRSA. So in admitted patients, the microbiological testing is undertaken based on the epidemiological characteristics, along with the blood cultures, sputum cultures, and HIV testing. And in the ICU patients, all these are done. Along with this, if the patient is having ventilator-associated pneumonia, the invasive bronchoscopy specimen is also considered for the diagnosis. This can be considered along with the risk-benefit ratio, again, being considered in your management. So in OPD patient setting, you need not have an etiological diagnosis. Whereas if at all you're admitting the patient, these tests are definitely necessary. The basic tests are being the cultures of the both blood and sputum, the HIV test, the respiratory viral panel, the urine streptococcal antigen, and the Legionella antigen, along with the COVID-19. And some patients may require MRSA testing. Again, as I told you, in all cases, this diagnostic, that is etiological diagnostic approach, can be modified based on the epidemiological exposure, which is patient-specific risk factors if he is possessing, and some clinical features, regardless of the severity or the treatment setting. Like if you are seeing the pneumococcal, if you have got an X-ray and you see the pneumococcal in the chest X-ray, this is a very characteristic of patients with a Staphylococcus aureus pneumonia. So in this patient, you can definitely get tested this patient for Staphylococcus aureus. If the patient is coming from some hotel stay, cruise ship, or is working in an AC unit, these patients are more exposed to the Legionella species. All these are like epidemiological risk factors need to be considered for the microbiological diagnosis. So you need to know the differential diagnosis of the community-acquired pneumonia. There are many differential diagnoses to be considered, especially in the acute setting. The non-infectious conditions do come into the picture, like it can be the CHF due to acute dyspnea, the pulmonary embolism can present with pleuritic chest pain, hemoptysis, and the dyspnea. The pulmonary hemorrhage can mimic lobar pneumonia, the atelectasis, the chemical pneumonitis, the drug reactions, the lung malignancies, the collagen vascular diseases. I think if somebody follow NEGM article, there is one recently published case history in the NEGM, I think in the month of June, that the patient of community-acquired pneumonia was found to have the vaginous granulomatosis on evaluation. Though vasculitis is also very common, and acute exacerbation of the COPD and ILDs are also need to be considered. And among the respiratory illnesses, any illness can mimic the community-acquired pneumonia, or they can coexist. This is very, very important. Like acute exacerbation of COPD can mimic community-acquired pneumonia, but they can also coexist along with the community-acquired pneumonia. So we know that the clinical compatible syndrome of this pneumonia is the development of fever and the cough with or without expectoration, then dyspnea. This is a it is a clinically compatible syndrome suggestive of community-acquired pneumonia. Whereas if you see the diagnostic criteria of this acute exacerbation of COPD, it is either increase in the dyspnea or increase in the sputum volume or increase in the sputum purulence. Any one among this is considered as the acute exacerbation of COPD. Fever is not a criteria in case of acute exacerbation of COPD. This particular triad is also called as the Anthonysense triad. Many of the patients usually tend to miss the diagnosis of acute exacerbation of COPD just because patient may not have fever, patient is normal on X-ray. All these are missed diagnoses, which makes the patient very vulnerable for the high morbidity and mortality. And again, consider the respiratory viral infections and acute exacerbation of asthma. Allergic bronchitis or the infective bronchitis is one of the very common mimicker of the community-acquired pneumonia. We should know how to differentiate between those two. So if you see the acute bronchitis, here the alveoli are normal, but the airways are filled with the mucus. In pneumonia, both the alveoli and some part of airways are both mixed with the filled with the purulent secretions. So cough can be acute or persistent in case of the bronchitis. Again, acute in case of this one. The dyspnea is very mild in case of acute bronchitis, whereas wheeze is the predominant symptom in case of bronchitis, whereas dyspnea is a predominant symptom in case of pneumonia. The acute bronchitis patient tend to have a low-grade fever or normal body temperature, whereas fever is very common in case of the pneumonia. And again, the chest examination, we know the differences here. We don't have any signs of consolidation in case of acute bronchitis, whereas pneumonia has definitely got the signs of consolidation. This is very, very important because the treatment is different in case of acute bronchitis and pneumonia. Pneumonia patient needs to be categorized based on the severity and decided the site of care, whereas acute bronchitis is a self-limiting condition where just supportive management is the rule. Now coming to the treatment of the community-acquired pneumonia. For most patients with community-acquired pneumonia, excluding COVID-19, obviously, the etiology is not known at the time of diagnosis, and the antibiotic treatment is purely empirical by targeting the most likely pathogens. If at all we are using some antibiotics empirically, we should know what all organism it targets. And we should know the pathogens which are most commonly likely to cause this community-acquired pneumonia vary with the severity of illness. As I showed you one slide, where the organisms are different in case of outpatient setting and ICU setting. We should also know about the local epidemiology and the patient risk factor for certain infections with the drug-resistant organisms. So in outpatient antibiotic therapy, where the patient is having mild pneumonia, patient does not have any organ dysfunction, patient does not have any respiratory distress, his pneumonia, his PSI is less than 2 and his curve 65-0. Here in outpatient settings, the empirical regimens are designed to target the streptococcal pneumonia and atypical pathogens. As I told you, it is here it is targeted organisms are the streptococcal pneumonia, H. influenzae, Legionella, the Mycoplasma, all these organisms. If the patient has got certain risk factors, like if patient is having some comorbidities, if patient is a smoker, or if the patient has a history of recent antibiotic use, so you need to consider the organisms of beta-lactamase producing H. influenza, Catarrhalis, Moraxilla catarrhalis, and methicillin sensitive Staphylococcus aureus. So you need to include the coverage considering these organisms. If the patient of mild pneumonia has structural lung disease, it is further advised to expand the coverage to include the resistant organisms like the Pseudomonas, E. coli, and Klebsiella. So in case of an acute community-acquired pneumonia, who is mild in severity and who is decided to manage on outpatient setting, if the patient is of less than age 65, is otherwise healthy, there is no history of antibiotic use, then the drug of choice is the penicillin group of antibiotics along with the either macrolide or the doxycycline. This is very, very important. The oral amoxicillin plus either azithromycin or clarithromycin or doxycycline is the treatment of choice in case of the community-acquired pneumonia who does not have any other risk factors. The dose of amoxicillin is 1 gram TID. This is very, very important. And azithromycin and clarithromycin. Nowadays, recently, the erythromycin has also given priority in the recent guidelines of the American Thoracic Society for the mild pneumonia in the outpatient setting. Whereas if the patient has comorbidities, if the patient is a smoker, and if the patient has used the antibiotic in the last 3 months, then we need to use the penicillinase inhibitor along with the amoxicillin, that is amoxicillin and clavulinate, along with the combination of the macrolide or doxycycline. We know that the atypical organisms are inherently resistant to this penicillin group of antibiotics. That's why the usage of the macrolide or the doxycycline should be there in a case of community-acquired pneumonia. Although there has been a lot of debate about the monotherapy in the community-acquired pneumonia, monotherapy is definitely not advisable for these category of patients, whereas in an otherwise healthy patient, the monotherapy can be considered. But this is very rare to get. For example, by the time the patient comes to you with a community-acquired pneumonia, he might have already taken antibiotics, or he might have already taken 2 or 3 group of antibiotics together. It is very common due to lot of quacks and the improper practices available in India. So that's why if you see the Icmr guidelines, Icmr mentions only the amoxicillin clavulinate with the macrolide as a treatment of choice, ICMR does not mention oral amoxicillin as a treatment in case of outpatient setting. So it is always better to use amoxicillin with clavulinate plus macrolide or doxycycline antibiotic. If you see the preferences between macrolide and doxycycline, the macrolides are definitely preferred because lot of evidence has been available, whereas doxycycline is less preferred compared to the azithromycin or clarithromycin. The dose of the amoxicillin clavulinate is different here. If you are using the 625 mg, then it has to be given TID. If you are using 875 mg, then it is given BD. If you are giving 1 gram dose, then you can give the OD dosage. This is very, very important. You should remember. So if the penicillin allergy is very, very common nowadays, this penicillin allergy can be of two types. One is either IgE mediated and another one is non-IgE mediated. So this IgE mediated, how will you identify IgE and non-IgE mediated means? IgE is an anaphylactic reaction. So this here patients is having urticaria, angioedema, anaphylaxis shock, all these things. So if the patient has a history of IgE mediated reaction to the beta lactams, so you definitely cannot use any other beta lactams also. Whereas if the patient has a history of non-IgE mediated reactions, like some maculopapular rash, if the patient has a history of maculopapular rash developing to the amoxicillin or amoxiclav, then it is non-IgE mediated reaction where the patient can choose the different class of the beta-lactam drugs, that is cephalosporins, especially if the history of cephalosporin tolerance is available in the patient. Then you can choose the third generation cephalosporin as the option instead of oral amoxiclav. Either cefixime or cefpodoxime can be chosen, again along with the combination of either macrolides or the doxycycline. If the patient definitely has a penicillin allergy which is IgE mediated, then you cannot choose any beta-lactam groups. Then the preferred alternative is the respiratory fluoroquinolone. That is, there are 3 respiratory fluoroquinolones available. That is either levofloxacin or moxifloxacin or gemifloxacin. Remember, ciprofloxacin and ofloxacin are not the respiratory fluoroquinolones. It is the levofloxacin, moxifloxacin, and gemfloxacin. And again, these patients are preferred in a patients with structural lung diseases. So prefer these respiratory fluoroquinolones only in patients of the beta-lactam allergy. Don't use respiratory fluoroquinolones in day-to-day practice for the outpatient setting. Especially in India, this has become a rampant practice to give levofloxacin without any evidence. This is very wrong because the tuberculosis is a very endemic disease in India, and levofloxacin is also considered as an anti-tubercular therapy, which makes the diagnosis of tubercular very difficult and very delayed, and even the resistance becomes very common if you use levofloxacin alone in a case of tuberculosis patients. So in India, the respiratory fluoroquinolones for a patient of mild pneumonia in an outpatient setting is not justifiable. If the patient prefers any alternative drug to the fluoroquinolones, there are 2 new drugs which are available here. One is the lefamulin, another one is the omadacycline. Lefamulin has been approved in 2019 by the FDA. Is a fluoroquinolone alternative. It is of the class of fluoromutilin group of antibiotics. This can be the entrance question. The newer drugs approved for the community-acquired pneumonia is one is lefamulin, another one is omadacycline. The lefamulin is a fluoroquinolone alternative, and lefamulin has a potency which is similar to the respiratory fluoroquinolones. Again, this has to be avoided in liver diseases, in the patients with QT prolongation and pregnancy. If at all you are chosen the respiratory fluoroquinolone to use, you should not combine these patients with the macrolides because they have got an additive effect on QT prolongation. The azithromycin, clarithromycin also prolongs the QT interval, and these respiratory fluoroquinolones also prolong the QT interval. So you should never combine the levofloxacin, moxifloxacin, gemifloxacin with the azithromycin or clarithromycin. This is a very important thing to remember. And again, omadacycline is a newer agent. It is active against the most community acquired pneumonia organisms, and which includes the Enterobacteriaceae in its coverage also. So if you look at the Harrison here regarding the initial treatment strategies for the outpatient settings, so Harrison also mentions the amoxicillin 1 gram TID with either a macrolide or doxycycline. So macrolides are azithromycin and clarithromycin. Remember the dose here, azithromycin is given as 500 mg on day 1, followed by 250 mg per day for 4 days. I have seen a lot of practitioners using azithromycin as a BD dosage. Azithromycin is never given BD. Azithromycin is always given OD. So for pneumonia, it is 500 mg on day 1, which is followed by 250 mg per day for 4 days. The clarithromycin is 500 mg BD. If you are using an extended release tablet, then you can use 1000 mg OD. The Harrison also gives the option of monotherapy with doxycycline or monotherapy with the macrolides. But in India, it is better to use the combination of amoxiclav with macrolides. And if the patient for the comorbidities, it is similar. It is either amoxicillin clavulinate or cephalosporin plus either macrolide or doxycycline. Sometimes the patient, if the beta-lactam allergy is there, then you can consider using monotherapy with a respiratory fluoroquinolone. Again, this is an American Thoracic Society guidelines. This is also same with the way we discussed. So for the inpatient antibiotic therapy, we need to consider some resistant organisms like Staphylococcus aureus, the gram-negative enteric bacilli, that is Klebsiella, E. coli, which are very notorious in causing gram-negative sepsis, in addition to whatever the organisms which we were considered earlier. And here we need to, the first dose of antibiotic in case of inpatient antibiotic therapy should be given within 4 hours of the presentation to the hospital. This is very, very important. And the key factors in selecting the regimen in inpatient setting are 2 organisms. One is MRSA, another one is Pseudomonas. So there are separate set of risk factors for these 2 organisms. If these patients are having this predisposition, you need to include the coverage. So in a patient of moderate pneumonia, you're decided to admit the patient, and patient does not have any suspicion for the MRSA or Pseudomonas, or does not have any risk factor for the development of MRSA or Pseudomonas, then the treatment of choice is the beta-lactam plus a macrolide or the respiratory fluoroquinolone as a monotherapy. Again, beta-lactams approved are the ceftriaxone. The dose is 1.2 gram IV daily. The cefotaxime is TID. I have seen many doctors of using Taxim as BD. Taxim is always given 8th hourly, not 12 hourly. And the ceftaroline, 600 mg BD. And again, some carbapenems like ertapenem, or you can use the combination of ampicillin, sulbactam, 3 gram 12 hourly. And the macrolides are used either IV or oral, azithromycin 500 mg OD. The oral dosage for the mild pneumonia is 500 mg on day 1, followed by 250 mg OD for 4 days. Whereas in case of hospital-based settings, it is 500 mg OD for 5 days. If you've chosen the patient to use respiratory fluoroquinolones, you can use the leofloxacin or the moxifloxacin and the gemifloxacin. Gemifloxacin is available only orally, whereas leofloxacin and moxifloxacin are available both IV and oral formulation. And leofloxacin dose is 750 mg OD and not 500 mg OD, which is usually available in the market. So it is 750 mg OD is the treatment of choice. If the patient has certain risk factors for development of Pseudomoral infection, like if the patient has a previous history of Pseudomonas infection, is a known colonization, like patient of bronchiectasis are very prone to have a chronic colonization. A recent antibiotic use in the hospitalization is a very, very important. Like if the patient was admitted 1 month back with a pneumonia, again come with a recurrent pneumonia, then we need to suspect patient having Pseudomonas pneumonia. Then the patient of structural lung diseases like COPD, bronchiectasis, and if you have seen some gram-negative rods on the sputum, which can be Pseudomonas, and frequent COPD acute exacerbations, patient is coming with frequent exacerbations, you need to suspect Pseudomonas, and patient obviously having immunosuppression need to be considered for the Pseudomonal drugs. The earlier guidelines considered the 2 drugs which are anti-Pseudomonal to be used in combination for the Pseudomonas, whereas the newer guidelines can be considered for using only 1 anti-Pseudomonal antibiotics. So as far as the anti-pseudomoral antibiotics, we have got two groups. We have got anti-pseudomoral beta-lactams. Then we have got anti-pseudomonas fluoroquinolone. The anti-pseudomonas beta-lactams are the piperacillin tazobactam, the cefepime, it is a fourth generation cephalosporin, the ceftazidime, then the meropenem, imipenem, and aztreonam. These are the penicillin group of antibiotics which possess the anti-pseudomonal activity. And among the fluoroquinolones, ciprofloxacin and levofloxacin are the only two drugs which possess the anti-pseudomonal activity. So remember the dose of piperacillin tazobactam, the very commonly used antibiotic, it is 4.5 gram IV 6th hourly. Again, if you have used, one important point to remember is ceftazidime does not possess a good activity against the pneumococci. So we know that we are covering here anti-pseudomonas not at the risk of having pneumonia, pneumococcal pneumonia. We need to have the antibiotic which have got significant action against all the typical organisms along with the resistant organisms. That's why ceftazidime does not make a good choice of antibiotics in case of what you call community acquired pneumonia. Whereas if you have ground the culture of Pseudomonas and if it is definitely sensitive to ceftazidime, it can be better considered for the usage. The levofloxacin, whether you use orally or IV, the dose is same, that is 70 TID. Whereas if you are using oral dosage, it is 750 mg BD. This is very, very important to remember. And if you are suspecting MRSA in a patient of hospital admission where you have got non-colonization or a prior infection, kidney patient, drug abusers, men who have sex with men, the prisoners, recent influenza, which is a very important risk factor, and on X-ray, he's suggesting having a cavitatory pneumonia or an empyema, you need to have an agent which have got an anti-MRSA activity. There are 3 or 4 drugs available for the anti-MRSA activity. The very commonly used is the linezolid, that is 600 mg IV 8th hourly, is a very safe drug which is renal safe. And vancomycin is a drug which possesses the anti-MRSA activity, and the newer cephalosporin, that is ceftaroline, possesses the anti-MRSA activity. This can be the entrance question. This is a recent drug approved for the MRSA, that is ceftaroline. There is another drug that is clindamycin, which can be used for MRSA, but nowadays the resistance to this organism is growing. Only after the culture sensitivity has been proven, the clindamycin use has been advocated. Otherwise, linezolid makes the good choice for the MRSA. There are some newer antimicrobial agents which are coming for the community-acquired pneumonia here. That is the lefamulin, 600 mg BD is been approved by the FDA. Then the omadacycline is also approved by the FDA. Then the dilafloxacin is a fluoroquinolone group of antibiotic, which is also approved for the community-acquired pneumonia. There are 3 drugs which are approved. There are 2 drugs at the verge of their approval. One is the solithromycin, under trial. Another one is the pneumonoxacin. These 2 drugs are under trial for the community-acquired pneumonia. So these 3 drugs are the newer antibiotics which are approved for both community-acquired pneumonia. Another one is the acute skin and the associated structure infection. The soft tissue infection, necrotizing pneumonitis, cellulitis, all these infections, these 3 drugs are approved. So this can be the entrance question. What are the new drugs approved for the community-acquired pneumonia? You should remember at least 3 drugs. One is lefamulin, another one is omadacycline, and dilafloxacin. The dilafloxacin is very costly. It is not yet available in India. It is $1,300 per 10 tablets. This is too costly. As lefamulin is pretty much available in India, it is 530 rupees per 10 tablets, 50 rupees per tablet. This is okay, can be usable in a patient. Then again, an ICU antibiotic therapy is almost similar to the patient admitted to the medicine ward, but the basic rule is don't use monotherapy. Like we can use the respiratory fluoroquinolone monotherapy for the ward patient, but the monotherapy of antibiotics is definitely not advised in ICU. In ICU, a patient cannot be on a single antibiotic. This is a rule. A patient of an ICU need to receive at least 2 antibiotics, be it any infection. And antibiotics need to be administered within 1 hour of the presentation into the ICU. Then again, for the disposition, the further management After the starting antibiotic is dictated by the patient response. The clinical response is assessed on the daily rounds. We have got various criteria to assess the clinical response, but again, the individualized decision is the best. And look for the subjective improvement of cough, sputum production, dyspnea, and chest pain. Among this, the last to go is on infiltrates. It takes around 1 to 2 months for the pneumonia to completely disappear on chest X-ray. Whereas first thing to improve is the systemic signs, that is the tachycardia and hypotension. And the cough and fatigue may take 2 weeks to get improved. So the antibiotic de-escalation is a tailored therapy. So if the causative identified is pathogen is identified, then antibiotic can be chosen to cover only that antibiotic. For example, if MRSA coverage was added empirically and you have done the culture or the screening swab and MRSA was not identified, you can discontinue the MRSA agent. Although the pathogen is not identified routinely, if at all you get to identify some organism, you can choose the antibiotic according to that particular situation. And again, this is a de-escalation criteria we usually use. If the patient is improving clinically, if the patient is hemodynamically stable, and if you identified the microbiology results, then you can treat accordingly pathogen. If you're not identified, then if the initial choice of fluoroquinolones were chosen, switch to oral fluoroquinolone. If the initial choice of the penicillin group of antibiotics was chosen, then put the patient on oral penicillin group of antibiotics. Duration of therapy is 5 to 7 days for usually hospital acquired or the outpatient settings, but it can be prolonged for some patients in ICU. Then there are some complications developing in the community acquired pneumonia. There are two very important complications. One is either clinical failure, other one is non-resolving pneumonia. Although these two looks like similar conditions, these are different. Non-resolving pneumonia is the patient is neither improving nor deteriorating. He's remained the same, whereas clinical failure is the deterioration. In clinical failure, patient has progressed to the severe sepsis or respiratory failure. There is no increase in subjective symptoms. There is some increase in subjective symptoms. The fever has increased, cough has increased, and some objective signs of worsening is also demonstrated. Whereas non-resolving pneumonia means the initial symptoms were not progressing, neither they are improving, even after the 7 days of antibiotic therapy. So for the clinical failure, you need to suspect either there is a progression of initial infection, like patient may have a dysregulated immune response, like patient has developed the SARS or cytokine storm, or infection might have spread beyond the pulmonary parenchyma, like empyema, lung abscess, or patient might have had endocarditis. Or if the organism may be drug-resistant pathogen, or the organism is very unusual, which is not susceptible to the antibiotics which we are giving. Or patient might have developed some comorbidities, like if he has acquired superadded nosocomial infection in the hospital, or the catheter-related bloodstream infections are very, very common. Clostridium difficile infection due to broad-spectrum antibiotics. Then some CV events are very common. The patient might develop the acute myocardial infarction or stroke during pneumonia, which can cause the clinical failure. The cause of non-resolving pneumonia is a delayed clinical response, like patient, the organism is susceptible, but it's delayed, or the infection has loculated, causing empyema or lung abscess, where the surgical drainage might be the treatment of choice. The bronchial obstruction, especially the post-obstructive pneumonia developing in a malignancy, is very, very common, which is not responding to the antibiotics. And the pathogens causing subacute or chronic infection, like what you diagnose the condition as community acquired pneumonia, but it is actually tuberculosis causing the pneumonia. Because it's very common in India, TB can present as community acquired pneumonia. For the community acquired pneumonia prevention, we have got 3 strategies. One is smoking cessation, another one is influenza vaccination and pneumococcal vaccination. For smoking cessation, we have got the psychotherapy, and we have got 3 pharmacological agents approved. One is the nicotine replacement, another one is drug called bupropion, another drug called varenicline. These are the 3 agents which are approved for the smoking cessation in adults. One is nicotine replacement, which is either gum or transdermal patch or nasal vaccination. All are available in India. The bupropion is approved for smoking cessation, and varenicline is a very recently drug approved for smoking cessation. This can be the entrance question. The influenza again is a seasonal flu. It is up. The influenza vaccination has to be done every yearly in the risk patients. Then pneumococcal vaccination, we have got separate guidelines regarding the pneumococcal vaccination. You need to go through the pneumococcal vaccination. There are two types of vaccination. One is 23 polysaccharide vaccine, another one is the 13 capsular vaccine available. Then the hospital-acquired pneumonia and ventilatory-associated pneumonia are very, very important. Here, the hospital-acquired pneumonia is the pneumonia developing after 48 hours of the hospital admission, and here it is 48 hours after the endotracheal intubation. The treatment is always same for both of the things, but this has got a very high morbidity, and some things you should know regarding this. There are very drug-resistant organisms which are involved in the hospital and ventilatory acquired pneumonia. The multi-drug means there are 3 different antimicrobial class resistant, at least one among these 3. If 2 group of antimicrobials, two class of antibiotics, if it is resistant, then it is called extensively drug resistant. If all the 3 group of antimicrobials it is resistant, then it is called pan drug resistant. What are those 3 groups? One is the beta lactams, another one is the fluoroquinolones, another one is the macrolides. If the organism is resistant to all the 3 classes of these antimicrobials, then it is the pan drug resistant. If it's 2 among 3, then it is extensively drug resistant. If any one among these 3, then it is multi-drug resistant pathogen. So we need to know the awareness about the local resistant pattern, which is very critical for the management of the patients. So if you know the organisms causing this ventilatory associated pneumonia, we should know the MDR pathogens which are responsible mainly. That is the Pseudomonas aeruginosa, the methicillin resistant Staphylococcus aureus, the Acinetobacter species, then the Enterobacteriaceae, especially the ESBL strains, then the Legionella, Burkholderia, and Aspergillus. Another one organism which I want to mention here is the Stenotrophomonas maltophilia. This is a very notorious organism in causing the ventilatory associated pneumonia and also ventilatory associated sepsis and UTI, all these things. So these organisms are very, very important. We need to have these organisms in mind while managing the ventilatory associated pneumonia. So certain risk factors are there for the MDR pathogens, like if the patient has received 90 days antibiotic in the last 19 days, patient is presented in the septic shock, ERDS is there, more than 5 days of hospitalization prior to the occurrence of VAP. Like if the patient was admitted for the moderate pneumonia in a routine ward, he has progressed to the severe pneumonia being in the ward, then you have shifted the patient to ICU. So this patient is definitely at risk for MDR pathogens. And if the patient is receiving the acute renal replacement therapy, where a lot of catheters are involved, a lot of blood artery punctures are involved, these patients are especially risk factor for the MDR pathogens. For Pseudomonas, if the ICU screening more than 10% gram-negative bacilli isolates are resistant to an agent which is being considered for monotherapy, then MDR Pseudomonas is considered, which has been similar for the Staphylococcus aureus also, because we routinely screen our ICUs, operation theaters for the organisms which are growing habitantly in the local environment. If the growth is more than 10% of the gram-negative isolates and they're resistant, then you should consider the Pseudomonas as the etiology. Again, the symptoms are very difficult to diagnose in the ventilatory associated pneumonia. But the best thing to identify is the ventilatory mechanics alteration in a patient of mechanical ventilation. For the patient admitted for the Guillain-Barré syndrome, is intubated, now coming with a new ventilatory mechanics, developing fever, new purulent secretions are appearing, new infiltrates are appearing on the chest X-ray, then the diagnosis of the VAP is considered. Whereas the new guidelines have been given by the CDC for the ventilatory associated pneumonia, that is called as ventilatory associated events, to carry out the early diagnosis. So if we know that first there are ventilatory associated conditions, like patient was stable for 48 hours on the ventilator, now he has developed new abnormalities, like his PEEP has risen, his FiO2 has risen, then this is called ventilatory associated conditions. And in a patient of ventilatory associated conditions, if he develops a fever or a leukocytosis or a leukopenia, then he is considered as having the either possible VAP or the probable pneumonia. Possible, we need to have the positive culture. Probable, if the culture is not ground. So how will you diagnose this patient of ventilatory-associated pneumonia? We have got some advanced imaging techniques. It is very difficult to get in a patient of mechanical ventilation, but we can have the respiratory sampling by some invasive and non-invasive methods. The invasive methods are the preferred things like the we can have a non-bronchoscopic methods like the mini ball, or the bronchoscopic methods like the brush biopsy, etc. Or we can just take the tracheobronchial aspiration. Sometimes the lung biopsy is used, but it is not used routinely in the daily practice. So we should know this thresholds for the quantitative diagnosis of VAP. The endotracheal aspirate need to have the 10 lakh colony forming units, and it is 10,000 for bronchoscopic or mini ball specimen. For brush biopsy, it is even the 1,000 colony forming units are significant. If you come to the treatment of the ventilatory associated pneumonia, if there are no risk factor for the MDR pathogens, then it is either piperacillin tazobactam or cefepime or levofloxacin is used. Whereas if it is the MDR pathogen suspicion is very high, then we need to choose the combination of either one of the antibiotics from the two groups. Whether it is beta-lactams or it is either aminoglycoside or the fluoroquinolone or the cholesterol, etc. And if you have got a MRSA susceptibility, then you need to use the either linezolid or the vancomycin dosage. So what all has been changed in the recent guidelines? The old guidelines use the terminology of the healthcare associated pneumonia, which has been removed nowadays. And coming to the important things I would like to mention here, the macrolides was the first option in case of this old guidelines, whereas the recommended macrolides is an alternative option for the outpatients without comorbidities. And erythromycin was not the option, but it is the new guidelines has considered this option. In the earlier guidelines, the IV cefuroxime was used, but now new guidelines, the cefuroxime has been removed as a treatment option, whereas ceftaroline has come into the picture, which is a very good antibiotic. Then earlier guidelines was advised to use at least 2 anti-pseudomonal agents together while managing Pseudomonas infection, but new guidelines considers even single use one antibiotic which is having an anti-pseudomonal coverage is more than sufficient. And here earlier guidelines also told to involve the anaerobic coverage for the aspiration pneumonia, whereas new guidelines does not recommend the routine adding of the antibiotics which are covering the anaerobics until and unless you have some empyema or suppuration or the lung abscess, etc. So this is very, very important here. To take some questions here, these questions are actually the questions asked in the previous exams. So which of the following is not a risk factor for acquiring ventilatory associated pneumonia? Option A is continuous sedation, aspiration of oropharyngeal or gastric contents, prolonged or mechanical ventilation, and reduced clinical staffing. So reduced clinical staffing is not a risk factor because we know that the human carriage or the hospital nurse carries the highest source of MRSA in the nasal cavity. So if you reduce the clinical staffing associated with the patient, it will reduce the risk of developing the ventilatory associated pneumonia. The components of ventilatory associated pneumonia care bundle include all of the following except elevation of the bed head is included. Regular oral care is definitely done. Making sure patient movement is limited while the ventilator is on is wrong. Sedation interruptions are very, very important in assessing the readiness to extubate is a very important care bundle in VAP. So how much degree of head elevation should be there? It is equal or more than 30 degrees is very, very important in head elevation in a patient on mechanical ventilation to prevent the microaspiration to occur. So I will give this particular presentations to you in the group. So there are some things, facts-based questions which are involved during this last 3 slides, that is the specific imaging findings representing some pathogens in the community-acquired pneumonia. You can go through these in the presentation. Okay, the one question which is there in the group is, can you tell what is ocal resonance and what is ocal fremitus? Okay, ocal fremitus and ocal resonance are actually both similar. The ocal resonance is used for basically as an auscultatory finding, whereas ocal fremitus used for the palpatory findings. But otherwise, for the basic mechanism and the method of demonstration is same for both. This is a very vast topic indeed to involve all the considerations of the clinical syndromes associated with the respiratory infection in one class, that in 1 hour. I have tried to cover the majority of important things for both the exam and clinical practice. Thank you, and we will get we'll come with a new presentation in the next week.
Thank you so much, sir. We could learn a lot in this class, and we need a guidance and support throughout. And to say, actually, a normal teacher just explains the topic, sir. Only a great teacher inspires the students, and you are a great teacher, sir. Thank you so much for inspiring us. And
thank you very much. I think in the last class, many of the students were asking for my contact number. I could not give it in the live class, but it has been available along with the details in the last class in the YouTube. So you can directly contact me if at all anybody having doubts regarding particular topic concerned with internal medicine, they can directly contact with me. And again, thank you very much for the support here and for giving us the opportunity.
Thank you so much, sir. I truly appreciate the time you spend in teaching us and the confidence you boost in us when concerned to medicine. It's incredible, sir. Thank you so much.
Thank you very much.